Thank you for being here. Okay, I don't have any disclosures. Okay, so in this short 15-minute, I'll talk about some of the vital statistics as it pertains to colorectal cancer, how CT colonography compares to the other available screening tools, the advantages, and limitations, and indications of CT colonography, and also how exactly is the study performed and reported, and where do we stand today with regards to insurance. So colorectal cancer continues to remain as one of the leading cancer-related, as a cause for one of the leading cause for cancer-related deaths. It is, in 2017 alone, it is expected to cause 50,000 deaths. But thankfully, there is a decrease. There's been a decrease in the incidence and the death rates, mostly due to improved screening as well as improved treatment. Screening rates, however, continue to be suboptimal. The national screening rate in the US is approximately 65%. And this means that 1 out of every 3 people who are eligible to be screened are not getting appropriately screened. And this rate is even lower in Black Americans, Hispanics, and people of the lower socioeconomic groups. There is an initiative to 80% by 2018, and this is by the National Colon Cancer Roundtable. It was founded by CDC as well as American Cancer Society, and the ACR, which is the American College of Radiology, has partnered with them in reaching this goal. So we all know that almost all of colon cancer arises from small polyps. Now, we also know that not all polyps turn into colon cancer. It's only a minute, approximately 10%, that end up being colon cancer. We also have a very long interval to intervene. It takes approximately 10 to 15 years, that would not be good, for a polyp to transform to colon cancer. And so all these factors make colon cancer an ideal cancer to be screened. And by removing these polyps before they become cancerous, we can decrease the incidence. So we have several options for screening. And of these options, recently there's been a lot of advertisements that you might have seen on Cologuard. So there are the stool tests, obviously, the fecal occult blood test and the DNA stool test. But these tests, if you go back to the previous slide, are more towards reaching at this stage. They are not preventing cancer in that they do not pick up the precancerous polyps, but rather geared towards identifying the early cancer before the patient becomes symptomatic. And then we have the other tests which are geared towards identifying the precancerous polyps as well. But of these tests, we know that sigmoidoscopy only looks about 60 centimeters or so of the colon. And double contrast Bayer enema, the sensitivity is so low that it no longer plays a role in screening. And so that leaves us with pretty much optical colonoscopy and CT colonography as our leading tests with the most effective rates for screening. So how does CT colonography compare with optical colonoscopy? So several validation tests have been, studies have been performed. And one of the largest ones is the Akron trial, or the National CT Colonography Trial. And this was a trial that was in part funded by NCI and NIH. The results of this was published in the New England Journal of Medicine. It was a multi-center trial. It involved 15 institutions, had a large cohort of average risk patients of 2,500. And this study showed that CT colonography had excellent sensitivity of greater than 90% when it came to a polyp size of greater than 10 millimeters as a threshold. So virtual CT colonography or virtual colonoscopy is actually similar, if not slightly better, to optical colonoscopy in detecting colorectal cancer, especially when it comes to the right colon. When it comes to detecting polyps at the threshold of greater than 1 centimeter, it is still similar to optical colonoscopy at approximately 90% sensitivity. But when it's in smaller polyps in the range of 6 to 9 millimeters, optical colonoscopy continues to be slightly more sensitive to CT colonography. The sensitivity for optical colonoscopy remains at 90%, whereas for CT colonography, it comes down to approximately 80%. Now, in polyps less than 6 millimeters, they are diminutive polyps, which are clinically insignificant because the risk of cancer in these diminutive polyps are very slim, and they are not cost-effective to remove these small polyps. Now, there have also been several studies which show that CT colonography is, patients prefer them over optical colonoscopy. So studies that sent out questionnaires to patients who had both studies, and all patients, or the studies indicated that most patients preferred to have CT colonography over optical colonoscopy. Now, it's difficult to evaluate the cost-effective analysis because several assumptions have to be made, and so these studies tend to be complex. However, with realistic input of assumptions, CT colonography has been shown that in a population, it can be effective and cost-effective in population screening. So what are the advantages of CTC then? It has increased patient tolerance because it is minimally invasive. There is no anesthesia needed, so that means the patient can drive himself to the test, and he can drive. There's no need for a ride, and so these have translated to increased patient tolerance. For the study, we have to distend the colon with a little bit of air, but this can cause some discomfort to the patient, but it is not pain that needs any anesthesia. And the risk of complications is also negligible. It's almost zero. It's 0.005 risk of perforation, much lower than what the risk would be had they have to go through regular optical colonoscopy. Now, although we look at the colon, it is still a CT scan, and so we also look at other findings in the abdomen and pelvis, and multiple important findings can be found. For example, kidney cancers and lymphomas are the most common incidental cancers that we sometimes pick up in these patients. We can look at the liver to see if there's hepatic steatosis, look at the bones to see if there's osteoporosis, look at the abdominal aorta to screen for abdominal aortic aneurysms. And so, apart from colorectal cancer, there's actually that we find more cancers through more non-colorectal cancers than colorectal cancers during a screening colonography. So the rate is for 1 in 300 patients, there is some kind of cancer that is picked up. So the limitations are, truly the only limitation is that it is not a therapeutic test, unlike optical colonoscopy. So if you find something which is a polyp greater than 10 millimeters, or 3 or more polyps in the 6 to 9 millimeter range, then these patients will have to undergo colonoscopy. So we at UT Southwestern, we are trying to work with our GI doctors where they can undergo the test on the same day. Right now, when there's a failed colonoscopy, they come back to us on the same day, and we are able to do a CT colonography on the same day, so the patient does not have to prep twice. Now, the other limitation that sometimes is used as a talking point is the radiation risk, but this is really a theoretical risk, and it's not really a valid argument. We use a very low dosage of 3 millisieverts, which is actually about half what the dose might be if a patient had to receive a routine CT of the abdomen and pelvis. So in explaining to a patient, you could say that it's equivalent to what a background radiation may be for a year in living in some areas. For example, background radiation, if you lived for a year in Washington, D.C., is 3 millisieverts. If you lived in Denver, it's actually 13 millisieverts. So the radiation risk is actually negligible. There are some contraindications. We do not want to screen these patients who are at high risk for having colon polyps, which would include IBD patients, patients who have hereditary colonic syndromes, because in these patients, they are going to, they're higher risk of finding a lesion which will need to be removed, and so we recommend that they go straight to optical colonoscopy. And obviously, in any conditions where they are having any acute abdominal symptoms such as diverticulitis, it would be not indicated. So the indications then would be average risk patients, elderly and old patients who are symptomatic, but optical colonoscopy might be too much of a burden on them, following failed colonoscopy, and also in patients who cannot undergo optical colonoscopy due to safety issues, such as in maybe patients who have COPD and they have an anesthesia risk, or they are on long-term anticoagulation and have a bleeding risk. So moving on to how exactly do we perform CT colonography and how do we report it? There are multiple steps to it, which starts with a good bowel prep is needed. Bowel needs to be distended as well. Scan technique is important. And finally, we'll look at how 2D and 3D data sets are reviewed and reported. So the bowel preparation is similar to what they might have for a barium enema or for a optical colonoscopy. It's a 2-day bowel prep with on the day 2, it's just a low residue diet, and the day before the test, they have a clear liquid diet. And then the patient on the day before the test also ingests laxatives. Commonly used are mag citrate and Dulcolax. What is different from the other preps is that for CT colonography, we also give them a small amount of what we call as tagging agents, and that would be a small amount of barium or iodine-based contrast. And the purpose of giving them this is that we want any residual stool that might be remaining in the colon to be tagged by this tagging agent, and so we can easily identify and differentiate what is stool and what is polyp. Once the patient arrives in the radiology department, the bowel is distended by the technologist. A very small, soft rectal tube is inserted into the rectum, and then the colon is distended. You can use either room air or carbon dioxide, but however, studies have reported that patients do better and are less symptomatic when CO2 is used, which is what we use. And it can be inflated, either automated or a manual insufflation. Once again, automated is going to be safer because you can set it at a set pressure. And if there was an obstructing mass or something in the colon, then the pressure would go up high and it would automatically shut off the insufflator. So then moving on to the scan technique. The patient is then scanned, once supine and once prone. And the purpose of doing this is that we want, it gives us a chance to distend maybe a portion of a colon that wasn't distended in one position. So we scan them in 2 positions, and that way we can ensure that all portions of the colon are adequately distended. The other important purpose that this 2-position scanning serves is that it helps us differentiate what a polyp is and what a piece of stool might be. So in this particular case, you have a supine patient, and then in the ascending colon over here, there is a polyp with a little bit of contrast that is coating the surface of it. In the supine position, in the prone position, that polyp continues to remain in the anterior wall of the ascending colon. If it was a piece of stool, it would have moved elsewhere. And so doing these 2 positions help us in identifying or in differentiating what is a polyp and what may be just a piece of stool. Now the scan is pretty quick. It takes less than 25 seconds in each position, and it can be also done in some of our sickest patients who are pre-transplant evaluation, who are too sick to even be on the prone position. So in such patients, we scan them in bilateral decubitus positions, once again serving the same purposes. So once we get the images, the computer then isolates the colon and creates 3D data sets through which we can then fly through. Here's an example where you have a 3D image of intraluminal image, and here's a picture of a polyp which is pedunculated, and at any given time, by clicking on the polyp, it automatically localizes where it is located in all of the other planes on the 2D data set as well. And again, by changing the window, we can evaluate it further and differentiate whether it could be a piece of stool, in which case it would be high in density because it would be tagged. There's an example over here. It's a much higher polyp-looking lesion within the bowel, which was actually just tagged stool. So let's see if this movie runs. Okay. And so this would be how you could look through. It looks very similar to optical colonoscopy. You can stop it at any time, and you can control the speed and analyze each of the lesions that you see as you go through. And in this case, there is a polyp, which it localizes on the 2D scans. The other thing it also does for you, the computer automatically places it in places it in the colon and gives you a distance from the anal verge to that lesion. So should the patient go to polypectomy following this, the GI doctors would know where exactly to look for the polyp. So moving on to how the study is reported. The purpose of this is that we want to have a consistent and a clear method of communicating our results to the physicians. So it's similar to BI-RADS. We have what is called as C-RADS, and what it does is it categorizes the findings into different. It classifies the findings into different categories and then gives them a recommendation for each of those categories. And similarly, the extracolonic findings are also categorized. So here is the table. C0 would be that it was an inadequate study. C1 is a normal and a benign lesion. Continue routine screening. I'll come back to C2. C3 are the ones that would go directly to polypectomy. So anybody with a polyp that is greater than 10 millimeters or a polyp that is more than 3 polyps in the range of 6 to 9 millimeters will go on to have colonoscopy. And then finally there is C4, which is obvious cancer and will have to be staged. So with the C2 or the indeterminate finding, this is in debate, but in general, the agreement is that when you have a polyp that is less in the 6 to 9 millimeter range and they are less than 3 in number, it may be reasonable to put these patients in a surveillance, and the recommendation is approximately in 3 years that they come back. Similarly, the extracolonic findings are also graded into categories, E0 being that the study was limited, E1, normal findings such as you might have seen a retroaortic left renal vein, or just a normal anatomic variant, which it still places it under the normal exam. E2 are clinically unimportant findings, but however findings that will be reported, but you don't have to act upon it, and those would be things like cholelithiasis, simple cyst, hemangioma in the vertebra. And then you have the potentially important findings, which would be cancer. There's a solid renal mass, lymphadenopathy, things that need to be worked on. So where do we stand with insurance is the big question. Right now, as things are, it is all private insurances should cover CT colonography. So as long as we have affordable care in place, which is questionable, but as long as that's there, they do cover CT colonography. The problem is with Medicare, which is still not reimbursing CT colonography. The USPSTF as well as the American Cancer Society do endorse CTC. However, Medicare is at this time only reimbursing for select conditions, and those would be if it is an incomplete colonoscopy, either due to a very long colon which was aberrant in the sense that it was very loopy and they couldn't get through it, in such cases that they would cover it. And also in cases where safety becomes an issue, such as anesthesia risk or coagulopathy, in such cases Medicare will cover. But in all other routine cases, Medicare does not cover at this point. I've just included some resources that you could use, links to some resources. So in summary, CTC is aimed more at identifying colorectal cancer and polyps, as opposed to some of the stool tests which are geared more towards identifying early colorectal cancer, and it is indicated in the screening of average risk patients comparable to optical colonoscopy. It is well tolerated by patients with almost zero risk and is covered by private insurances, but and select indications by Medicare. Thank you.